I'm Professor Martin Marshall, a GP in East London and Chair of the Royal College of General Practitioners. The whole general practice team plays a vital role in caring for over 500,000 people who die in the UK every year. Around 60 to 75% of deaths are at some point predictable, giving an opportunity for us to work in partnership with people and supportive networks within our communities to help plan their care better. The Royal College of General Practitioners recognises end-of-life care as a clinical priority. With general practice facing increased pressures on workload and capacity, the College is committed to helping general practice to be as well prepared as possible to deliver consistent, well-planned end-of-life care relevant to their population. Evidence tells us that improving care and support for patients and those important to them has a big impact on people's experiences when facing serious illness, end-of-life care and bereavement. A great place to start is to have a look on the RCGP website and sign up to the Daffodil Standards, aimed to help you support quality improvement across your whole population. Whether you select one or multiple standards to do over the year, the most important thing is to start somewhere. Each improvement step counts. Quality improvement does not have to be difficult. Small steps and changes can result in significant improvements. The Daffodil Standards are the UK RCGP and Marie Curie general practice standards for advanced serious illness and end-of-life care. There are 8 standards with a blend of quality statements, evidence-based tools, reflective learning exercises and quality improvement steps. Here we will look in more detail at how your practice can approach the retrospective death audit to support whole practice learning, to improve the experience of care and support for people affected by advanced serious illness and end-of-life care. The Institute for Healthcare Improvement model for improvement suggests you need to answer 3 fundamental questions for any quality improvement project, and then use PDSA cycles to test change ideas. Analysing baseline data is key to assessing your starting level, where you want to focus your improvement efforts and what impact your improvement is having. Step 1. Clarify who are your end-of-life care named leads, clinical and non-clinical, for the practice. They can help support a culture of reflective learning and improvement, enabling reflective discussion with the practice team and supporting change ideas to thrive. Step 2. Share the ambition to improve the experience of end-of-life care for all patients and those important to them. Step 3. Start your retrospective death audit. Run a quick search of approximately the last 20 deaths and fill in the audit template. Remember, it's not just cancer deaths or deaths of people on your supportive palliative care register. Consider care not only in the last few weeks or months, but also in the last years of life, where planning care and support is helpful to the patient and those important to them. The majority of audit measures are routinely coded, and a few, such as information documented within the personalised care and support plans, may benefit from review of the clinical notes. When collecting your data, it's helpful to review how consistently information is coded. As you consider what's important to audit in your practice, you could also think through the processes needed to support regular audits. For example, which codes you want to routinely use and monitor, and that all staff know exactly where to look for it, particularly in an emergency. Add up your results for each measure in order to start to build a picture of your baseline end-of-life care practice. Step 4. Once you've collated your results, have a practice meeting to discuss them, triangulating with information you have from patient feedback or staff views to form your baseline picture. Consider what are the priorities for your practice to improve, what's feasible and relevant. Now, with your practice team, set your SMART goals. For example, your SMART goal might be to increase the percentage of those who die who are on the palliative care register prior to death from 20% to 60% by an agreed date. Step 5. Another helpful phase in quality improvement can be to look at why something isn't already happening. For example, if a high number of deaths are occurring in a hospital for patients with COPD, then some kind of root cause analysis using a fishbone diagram or 5 whys can be used. You've done your baseline diagnostics and goal setting, so now generate your change ideas. Be as inclusive as possible. Collect ideas from as many relevant people as possible, group these into themes, and create a driver diagram to help you visualise the potential changes and how these relate to primary and secondary drivers and your intended aim. Once you have your driver diagram and a pile of post-it notes with change ideas on, consider putting them into a grid. Those that are high impact but easy to do are probably a good place to start. You know your practice population best. Make sure any comparison takes into account your relevant demographics. Share your SMART goals with your local GP network and ask for robust challenge to consider if your ambitions are feasible and relevant. Agree to bring back your learning at your next meeting. Step 6. Test your change ideas with your first PDSA cycle. Plan, consider one change at a time. Do, make your change. Study, plot your data on run charts using Excel to help you. Act, if your change is resulting in improvements. Go back to the start of the PDSA cycle and plan your next change idea. Continue to monitor until you're sure you've embedded change ideas and new processes into routine team practice. Step 7. The process doesn't end there. Celebrate and share successes, challenges and learning. Consider Daffodil Standard 1, relevant learning needs for clinical and non-clinical staff. And consider using a SWOT framework for discussions with staff about their training needs. Explore if these are common learning needs across GP peer networks. Re-audit. Choose your next project and start the process again, encouraging a no-blame, active learning culture. Be sure to share your learning, whether your change is successful or not. Others can learn from your experiences, and sharing this is an important part of the quality improvement process. We would like to thank NHS England and NHS Improvement for commissioning the development of this resource to help support general practice improve end-of-life care.